Okay, good morning. Well, today we're going to talk about updates in colorectal cancer. There's been lots going on, and I would love. It's a pleasure to be able to update this for you today. The objective of our talk is to discuss the role of colorectal cancer screening and look at the role of surgery in the treatment of colorectal cancer, and finally to give information on new ways to give radiation and chemotherapy. So screening, I'm going to ask somebody to type in the chat box, please, at what age we should begin screening for average risk individuals for colorectal cancer. Do we have an answer? 40, 45, lots of answers. Okay. Need to get out of this chat box. The answer is indeed age 45, and here we go. In 2017, initially the U.S. Multi-Society Task Force recommended in overall age to begin screening of age 50, but 45 for African American individuals due to their higher incidence of malignancy with colorectal cancer. In 2018, the American Cancer Society issued a qualified recommendation of age 45 to commence general colorectal cancer screening. And this really was as a result of a significant decline in the observed median age of diagnosis of colorectal cancer. We used to think of it as a disease of the elderly, and median age was 72. But then when we looked at data that spanned 2005, that should have been 2005 to 2016, that fell to 66. And then as a result, the U.S. Preventive Services Task Force in 2021 recommended age 45 as the age to start screening for patients who are otherwise not at high risk. So what are the options for screening? What are the options are the first tier tests are colonoscopy and FIT tests, and second tier tests are CT colonography, which is basically a scan of the colon, as well as the DNA-based stool test, the Cologuard. However, the U.S. Screening Preventive Task Force actually recommends that any of these assays that people are familiar with and comfortable with are reasonable to do. So the message is just screen, whichever one you choose. But do keep in mind that if anything but a colonoscopy shows that there is a risk of a cancer or potential cancer, then patients will need to have a colonoscopy for the diagnosis and then removal of any abnormalities. So we talked about the options. We also talked about that we need to emphasize that overall the goal for screening for it to be really effective is that 80% of eligible people should have their screening done. However, we know that only 2/3, about 67% of Americans are fully compliant with colorectal cancer screening. And that probably got worse over the last 2 years during the pandemic. So for that reason, Providence has a major focus on helping people in the community and the community that it serves to achieve screening in a timely manner. And this is a committee that has been tasked, a group of leaders and providers and researchers that has been tasked with ensuring that the screening that should happen does happen. And this is a major initiative, and you can see that we had a number of national partners, including Stand Up to Cancer. And the major objectives the aims are as follows, is to use chat groups, which are community health action teams, to achieve the following aims: use community-based participatory design to convene and support chat teams, to design and execute a community campaign to increase colorectal screening rates. In addition, the chats will partner to design and execute a longitudinal study to showcase and determine the value of colorectal screening interventions in key screening parameters. Finally, a implementation study will be conducted to help us catalog the optimal strategy for improving screening. So what does this look like? So the screening study that will be conducted will involve identifying patients in a defined zip code that are in that Providence serves, and initially it needs to be stated this initiative initially will be conducted in the St. John's Providence Hospital in the LA region before it rolls out to other communities, including ours. So there will be a community campaign and then a follow-up assessment about the value of the screening campaign will be conducted. And the main measures are screening rates and test rates and behaviors and the knowledge of people about screening, and whether we missed anybody when it comes to screening, because we know there are disparities when it comes to screening. Not everyone has good access, not everyone has good information, and that's really what this campaign is all about. So where are we today in 2022 with colorectal cancer? So surgery is a standard way of treating colorectal cancer. We know that. When it comes to rectal cancer, a permanent ostomy is essential in about 25% of cases. So that is still not a great way, not a great solution for many patients who need these bags. We know that colorectal cancer does lead to distant metastasis if it's not detected early. And as a result, it is the #2 cause of cancer death in men and women combined. It's the #3 one if you look at men and women separately because of the prostate and breast cancer in men and women respectively. We also know that there's issues when it comes to excessive toxicity as a result of treatment, particularly among patients who receive both surgery and radiation. For patients with rectal cancer, we only radiate patients with rectal cancer. And we know that if patients have both surgery and radiation, there is a high rate of 5-year severe incontinence that is increased compared to surgery alone. So where does colorectal cancer, come from? We actually know that the majority of individuals that develop a colorectal cancer, approximately 75%, really have no prior history or family history that they know of. There are some syndromes, the polyposis syndrome and FAP, familial adenomatous polyposis, that are very well described and put people at risk of colon cancers at quite a young age. And we also know that the Lynch syndrome, also known as HNPCC, is another cancer syndrome that's well described. And then in another 10 to 30% of people, they have a history of colon cancer that we're quite suspicious of in their family, but we don't know what the gene is. So when we do the genetic testing, because they have such a strong history, we don't find a gene, but we really suspect there's something. So that's why we still need to do lots of work on, identifying the genetics of colorectal cancer. So what's the biology? Overall, again, this is a schema of the colon and the rectum. I'll start, with the distal. We call it the distal, so the very end. The first approximately 15 centimeters of the last at 15 centimeters of the digestive tract going, starting from the end, is the rectum, and then comes the sigmoid colon, which is on the left of the body, and then it crosses over right underneath the diaphragm to the right, and then it goes down again to the right colon, and at the very end of that is the appendix. And then if you kind of were to go further, you'd end up with all the small bowel, and then the small bowel goes into the stomach, and the stomach is connected to the esophagus. So that's really, that's what the organ, this is an organ, the rectum is an organ, and the colon is an organ, and they have design function. And that's the organ that we're talking about, that where the cancers can happen. And what are the factors that influence biology? Race does play a role. We talked about that African Americans tend to be at higher risk of colorectal cancer. Obesity plays a role, and excess fat in diet in terms of too many processed foods. Gut flora, we know that the biome is bacteria. Everyone has about 5 pounds of bacteria in their body, in their gut. And sometimes the balance of these bacteria can lead to a higher risk of colon cancer developing, particularly bacteria like Fusobacterium. So if people take a lot of excess antibiotics, that can destroy the balance and make it more likely for these less good bacteria to dominate. And then there's the episome, which is kind of the genetic aspect that is not related to family history, but is the kind of the genetics that you acquire throughout your life. And so as a result of these factors, they can converge to alterations in the cells that line this tube, this digestive organ. Those are the cells, the ones that are in the surface of it, that are exposed to all these toxins, that are to the, the meats, that are exposed to the meats, that are exposed to the high-fat diets, that are exposed to bacteria. Those are the cells on the surface that eventually can develop some abnormalities, and then these progress, and eventually the tumor grows to the bowel wall and spreads if we don't catch it early. So how do we treat this? So for colon cancer, the number one way to treat colon cancer, once you diagnose it with screening, is surgery. Ideally, we offer it laparoscopically. We have seen, there is surgeons that specialize in colorectal cancer are called colorectal surgeons, and that is a subspecialty. And I would recommend that if you need colon surgery, that you have it done by a colorectal surgeon. There are many that serve, that work at Providence, and they have their independent groups as well, and we work closely with them. They often can offer laparoscopic surgery, which is just 3 little incisions, and that is because the surgery is so much smaller that it results in a very short hospitalization stay and low blood loss. After the surgery is done, we consider whether there's a role for chemotherapy. And generally, stage 1 patients, we don't offer chemotherapy because there's really no risk of it coming back. Stage 2, we look at risk factors, and I'm going to describe that a little bit later on, how we do that. And stage 3 means that the tumor went to the lymph nodes, and those we know have a higher risk of coming back. And so we do offer chemotherapy for them. But there's changes coming of how we consider people for chemotherapy that I'm also going to talk about. So what about rectal cancer? Rectal cancer is more complicated. Why is that? Because the rectum is at the very base in the pelvis. So the surgeons, that's a kind of crowded space, so the surgeons have a harder time cleaning out the tumor and all the nodes around it. So extra therapy is needed to do that, including radiation. So this is an abbreviation called CRT, or RT, which is chemotherapy tablets combined with radiation, or radiation alone is usually given before surgery for patients with rectal cancer, then they have surgery, and then they get chemo after. So this is different than colon cancer. Now, what we're doing as of really only 2 years ago, we're starting to offer patients all the therapy they need before the surgery in an abbreviation called TNT. So medicine, doctors and nurses love abbreviations. So this one's called TNT. And so that involves doing chemo and then followed by radiation and then surgery, or chemo and or radiation or radiation alone followed by chemo and then surgery. So we did a recent study that we reported last year on how have things changed? How do we in America, this was an American study. I did a similar study in Canada when I lived there, but when I came to the United States in 2017, I wanted to understand and help us understand how we treat rectal cancer. And so what we did is took the national database of all patients diagnosed with cancer and over a period of 10 years between 2006 and 2016. And there was a little over 32,000 patients. And what we noticed during that time is more and more, if you look at the bottom row, the people receiving post-operative chemoradiation decreased, and in favor of doing pre-op chemoradiation and the chemotherapy after. So that's been a big trend, and that was actually a really important thing to see, because as we'll see in a moment, there's data support that you should really be giving post-operative, not be given post-operative radiation. You should try to do it before. So then we looked at how did this affect how patients are doing. And what we actually showed that over the years between 2006 and 2016, the pathologic stage, so the stage of tumor that the surgeon eventually removed after when they did the surgery, trended to a lower stage than in previous eras. So the light yellow colors are the lower stage and the dark colors are the higher stages. So as you can see, between 2006 and 2016, that decreased over time. And then we asked the question, well, how did that affect the survival? Like, did that help the patients at all? And what we actually saw is that the mortality risk, the chance of dying, was significantly between 2006 and 2015, significantly decreased with a hazard ratio of 0.77, which means there's a 33% reduction in risk of dying of colorectal cancer during that era. So we know that we're doing better when it comes to treatment, but I'm going to say that we still need to do better. So why do we need to do better? Because cancer therapy, there are issues. And, if patients that have rectal tumors, 25% of them still need a bag. We also know that even when we cure the cancers, there are long-term toxicities. It's called LARS. And with bowel control, having to go to the bathroom, eat quickly, and 50% of that people have that 5 to 14 years later. We also know that that this cancer does come back. It does come back in spite of the chemo and the surgery and the radiation. And this is the average of risk of it coming back. And so this is a metric that we use to define what is the likelihood of patients being free of cancer 3 years after they have curative cancer surgery. And unfortunately, even in the modern era, the chance of being alive and free of cancer is only 70 to 75% in these higher risk stage 2, 3 cancers. The great news is that, colorectal cancer has really changed. We're talking about it. We talk a lot about breast cancer. We talk a lot about, lung cancer. But, now we're starting to see that patients are really engaged and they want to be involved in decisions about how their cancer is treated. And there's a bunch of groups, I'm talking to you, the Asian Health Services group, that's a fantastic group. There's other groups nationally that focus only on colorectal cancer, and one example is Colon Town, and they're on Twitter and they're on Instagram, and what they do is they really help people understand their cancer and talk to other people with cancer. And I've actually referred people to these websites, and they've thanked me for engaging them with this very reputable group. And because we know they have to be careful online, because there's a lot online and it's not all true. So we just have to be careful with that. So what are we trying to do differently? What are the new strategies? Well, the new strategies are as follows. We're trying to do more with less. So what does that mean for surgery? For surgeries, we're trying to do non-operative management. I told you surgery is still standard, but we're trying to get away from doing surgery for everyone. And that strategy is called watch and wait. We're trying to do minimally invasive transanal surgery. It's called organ-sparing surgery. And then, of course, surgeons are doing laparoscopic surgery that I just told you about. What about radiation? We're doing studies, and we have done studies to use radiation less. And what about chemotherapy? So over the last 5 years, we're giving a lot less chemotherapy because we've done studies that have shown that 3 months is enough for most people with stage 3 colorectal cancer. And then finally, I'm going to be talking about the role of circulating tumor DNA in patients with colorectal cancer and how that can help us. I'm just going to make sure my computer is plugged in because I see a red light. Yeah, I think it is. All right, so let's talk about this. So the first approach, we talked about TNT, and this is the national guideline for treating cancer. We talked about TNT with rectal cancer, and this is patients with stage 2 or 3 rectal cancer that have received chemo and radiation, or the reverse sequence, and then they're restaged, and then a proportion of them will have a complete response. It's called a CCR. Remember, I told you, doctors like abbreviations, complete clinical response. So for those patients, we're now talking to people about non-operative management. So how does that look? Non-operative management, or watch and wait, is particularly done in the rectal cancer setting, and it's done to avoid surgery in patients whose cancer completely responds to both chemotherapy and radiation. This is predominantly interesting for patients with low rectal tumors when a permanent bag is needed. So what does this look like? Again, you give TNT, and then you assess the tumor. And if they have a complete response or a near complete response, we talk to them about watch and wait. So what does watch and wait mean? Well, it actually is quite a bit of work. So, you as a patient, patients need to be, willing to do that kind of work, because it's, and be able to be in a position to do these frequent evaluations. And that really requires a Q4 monthly scope, a rectal scope, and then a Q6 monthly MRI. So, and then those are done quite frequently, generally up to 2 years, and then less frequently. And then surgery is only done if there's evidence of the cancer coming back. So this is a trial called Oprah, and it was done to look at, this was a study, a major Canadian and US study that was done to look at the success of organ sparing and watch and wait therapy in patients treated with TNT for rectal cancer. And as you can see, for patients with a CCR that have a complete clinical response after chemo, radiation, and chemo, there had a 3-year chance of not needing surgery of 78%. If the tumor shrank down well, but you could still see some, the chances are, so it was near complete response, then the chances were only 45% that they didn't eventually need the surgery. And if they had an incomplete response, in other words, we still saw tumor at the end of the chemo, radiation, and chemo, then the chance of them not needing surgery was quite low. So this study has given us some understanding about what we can expect for patients who undergo TNT. So what about stage 1 rectal cancer? Stage 1 rectal cancer is a very early tumor. It's just gone to the surface and into the bowel, but not through the bowel and not to the lymph nodes. And in the past, we've known that you still need to treat this with surgery, and a bag is needed if the tumor is low. But there have been a lot of trials in the past that looked at giving chemoradiation and then doing a special surgery called a transanal surgery, where the surgeon just has to scoop out the cancer. So very appealing, and it generally was successful in about 50 to 65% of patients. But there was a lot of issues with these studies because patients first had radiation and then the surgeons cut into the tissue that was radiated, and they had a lot of problems with healing and pain. So what we did, we did a study, a national Canada and US study called the CCTG-NEO trial, where we gave patients chemotherapy and not radiation, and then we gave them these organ-sparing surgery, and we found overall that 79% of them were able to not have a big surgery. So just a minimal surgery. So we presented this last year at a national meeting, and really this study, and I won't go into too many details, but overall, we took patients with early stage rectal cancer. We gave them 3 months of chemo. We looked at them, and if the tumor responded well, they just had an early surgery. And if the tumor responded nicely when we removed the tissue and whatever was left, then we offered them what was called organ preservation, just observation. However, if there was still a lot of tumor left on the tissue that the surgeon scooped out, then they really needed a bigger surgery. So these were the results. Overall, initially, we did see 50% of them, 57% of patients had a really good downstaging of the tumor. However, a total of 79% of patients had eventually proceeded on an observation alone. In other words, they didn't proceed to radical surgery that would have otherwise have been recommended. So of the 58 patients that were enrolled, 46 of them eventually had an organ-sparing strategy in the study. So we, because of the success of the study, we're doing a larger national study. And this is really, as we were following the patients, this was the risk of recurrence in the patient population that we treated on the trial, and it was really low risk of recurrence. So far, the results are very promising. Okay, just getting back to the objectives. What are the other strategies to improve therapy? Now I'm going to talk about radiation. So just to kind of summarize what has been going on when it comes to radiation, particularly for rectal cancer. Remember, I told you that only patients with rectal cancer need radiation, not colon cancer. So overall, the evidence that we've gathered over the past 20 to 30 years really is as follows. And the Swiss and the Dutch demonstrated in all the way back in the late 90s and 2001 that patients should be treated with radiation before surgery. And then in a large German study, they compared doing radiation before surgery than radiation after surgery. And it was a different type of radiation with chemotherapy. And even there, the recommendation was that radiation with chemo should be done before surgery. And that's important because I don't know if you remember, but I showed you that graph of the United States and all the patients that got post-operative radiation, how that really decreased over time. Well, this was back in 2004, this evidence came about, and it really took about 10 years for people to, doctors to stop radiating patients after surgery and do it before. So that's why that study was important. In 2014, the British established some really important data that told us that MRI is critical in defining how and looking at rectal cancer before surgery is done to decide on whether or not radiation is required. And in 2020 and 2023, that will be coming up. The Chinese as well as Americans have done really important studies in order to ask the question is, do we need radiation for everyone with rectal cancer, or can we avoid radiation for some patients? And this is really the study. This is the name of that study. This was the American one and that finished accruing and was called Prospect. And it basically took patients with stage 2-3 rectal cancer and randomized them either to the standard arm, to radiation, followed by surgery, followed by chemo after, kind of the old-fashioned way, or to treat them first with chemotherapy, and then to look at the tumors again. And if the tumors shrank down nicely, then they would go right to surgery and no radiation. So in other words, we're trying to figure out ways to not radiate everyone, because we know that if you do surgery and radiation, you have a lot more side effects. So we're going to get the answer from that study in 1 year. So what about chemotherapy? So we've been giving chemotherapy to decrease the chance of the cancer coming back, to cure patients with colorectal cancer for over 30 years. The initial data, and this comes from many studies done in many different countries, showed that fluorouracil given for 6 to 12 months decreases the chance of cancer coming back by 40% for people with stage 3 colon cancer or rectal cancer. In 2004, a French study primarily looked at the value of adding another drug to fluorouracil by the name of oxaliplatin in a recipe called FOLFOX, and giving that for 6 months. And it found that that decreased the risk of cancer coming back by 55% overall for stage 3 colon and rectal cancer patients. So really important way to treat colorectal tumors after surgery. In 2017, again, through really global trials done, in Asia, in Europe, and North America, we asked the question, do we really need 6 months, or is 3 months enough? And that was quite a daring question, but it was prompted by a lot of people having side effects from the FOLFOX, from getting a lot of numbness. And we know that in many cancers, about 3 months is about all that's needed to cure the cancer. And indeed, the answer was 3 months is enough for most patients with stage 3 colon cancer. Or rectal cancer, in other words, tumors that have gone to the nodes. For those with high risk colorectal cancer that have gone to 4 or more nodes, we did see that using 6 months of therapy is preferred. Finally, the current and a very exciting way that we're trying to change the practice of colorectal cancer is looking at circulating tumor DNA to try to predict who needs chemotherapy and who does not. And I'm going to present some data on this in the latter part of the presentation. I want to make a comment about immunotherapy and the role of immunotherapy in colorectal cancer. Overall, in MSI low, which is a way to categorize colorectal cancer, we always do this test to see if they're MSI low or high. And the majority of tumors are MSI low. We know, unfortunately, that immunotherapy is not effective. We're still doing studies combining immunotherapy with other drugs or in certain patient population. In some colorectal cancer settings that have MSI high, and that's a simple test that everyone that has a diagnosis of colorectal cancer, that test should be done, and we make sure that it's done on their tumor to tell us whether their tumor is MSI low and MSI high. MSI high tumors are more common in the early stage 2, about 15%. In stage 3, it's about 10%. In stage 4, it's about 5%. They really benefit from immunotherapy, with an 80% or more of them benefit from this therapy. And for that reason, it's a really important marker to do at the time of diagnosis. So here's an example of immunotherapy for, this is MMR. I'm sorry, there's different ways of saying MSI high is also called DMMR. And so it's called the mismatch repair defect. So these are the same thing and with a different name. And so patients that have DMMR rectal cancer that are treated with immunotherapy, this was a study that was just presented in the United States at the GI ASCO. It treated them with immunotherapy for 6 months, and they had this certain marker. And then they looked at, is there any tumor left? And what they saw is the complete clinical response rate was 100%. In other words, the immunotherapy took care of the cancer in 100% of the tumors. So we actually think this is really going to change the practice of colorectal cancer, because it will allow us to cure patients with less therapy. Again, this is where we do the non-operative management, the organ sparing, the watch and wait. So that's what's going to happen to these patients. Finally, the last part of this presentation, I would like to talk about chemotherapy and how we're starting to use circulating tumor DNA, which is abbreviated ctDNA, in post-operative therapy. So what does this mean? So let's take a step back and talk about us seeing cancer in patients that have had their cancer removed, and we're checking up to see that it makes sure it's not coming back. Well, 100 years ago, when all we could do was X-rays, then it would take 1 billion cells, in other words, 10 to the 9, so this nodule, a cubic centimeter, to be detectable on a chest X-ray. So that is really, we were only able to detect tumors really when it was pretty much too late. And then CAT scans have come along, and they can detect smaller tumors, but still you need about 100 million cancer cells in order to be able to 10 to 100 million cancer cells in order to see it on the CAT scans. And you can see a small nodule here. Well, the promise of circulating tumor DNA is that we can now detect cancer in the body, even if it's in very low amounts and only 10,000 cancer cells. And we now have blood tests that can detect that. So what is that? How do we do that? Well, and why do we want to do that? So what these circulating tumor DNA tests do is they can detect residual cancer among patients that have had complete surgery, and they had no evidence of cancer on CAT scans or PET scans or MRIs. And that's really how it looks. After resection, we know that many people are cured, but we also know that some people, cancer will come back. And that's where trying to find these cancers early before we see them is important, because if we can detect them in the blood, but then that still offers a chance of being able to cure them. That's called minimal residual disease, or sometimes abbreviated MRD. So this is where we're currently going, is we're doing surgeries, we're finishing therapy, and then we're starting to do these DNA tests. So how do these DNA tests work? Well, there's 2 currently approved ones. They're simply blood tests. They're very specialized blood tests. And there's two products on the market, Guardant Reveal, which came on the market in 2021, and Signatera, which came on the market in 2019. And both are covered by public insurance, Medicare, Medicaid, as well as private insurance, specifically for patients with stage 2-3 colorectal cancer. In other words, in patients who the surgeons have said, I finished the surgery, well, then they come to see doctors like me, and then we say, okay, we need to really check to see if all the cancer is gone. And this is the value of these tests. And for the Guardant Reveal test, when we did the marker and we kind of divided people into being positive or negative, so you could not detect the tumor, that in the ctDNA, that's in the top line, and you could detect the tumor in the blood, that's in the bottom line. So what about the Signatera assay? Well, the top line is where we couldn't detect the tumor in the blood, and the bottom line is where they could. So you can see right off the bat, it's a very, very powerful way of determining what's going to happen to people, to the tumors, if you don't do anything else. So how does this work? This is great technology, which really is built on whole genome and whole exome sequencing. Some of the tests, they take the original tumor that the surgeon has removed, and then we find the mutations for it, and we look for the mutations in the blood. Other ones use those mutations, but they also look at DNA methylation patterns, as well as fragments of DNA that can only happen if you have cancer in your blood. So those are the technologies that are being used at the molecular level. So what are we moving towards? We're using these tests to assign chemotherapy. So we're doing the surgery, we're seeing the patients, and then we're trying to check whether or not the tumor is still there. And if we can't find it, then we declare people cured. And if we can still find it, that's when we say we need to do chemo, and we probably need to do better chemo than we used to. So there's a number of trials that are ongoing, and I didn't give you all those details about the trials, but overall, we can use these tests, and we offer them to our patients, and we discuss the results, but we also have trials to try to help us use these tests in a better way. And really, this is also from January of this year, where there was some early data from Japan that described what happened to people that had these that had positive ctDNA and they received chemotherapy compared to positive ctDNA that didn't. So this is the graph on the top left, and this is all patients that were ctDNA positive and that had a history of stage 1 through 4 colorectal cancer. And then if you look at how they did, the ones that received ACT, that's with chemo, the majority of them cleared it. But if they didn't receive anything else, then the majority of them were positive, and eventually they developed relapse. What about the people that were negative? So that's the bottom graph, and this is survival according to receipt of further chemotherapy after surgery, according to for people that had a negative, in other words, no circulating tumor DNA in their blood, and they had a history of stage 2 or 3 colorectal cancer. And this is really a stunning result, because we can see that both groups, whether or not they did chemotherapy, did very well. And the lines were essentially superimposable. And that really points to the possibility that we are able to identify who needs chemo and who does not. So we need more data on this, but it could be really a change in how we talk to people about chemo. So in conclusion, screening is very important for colorectal cancer, and we need to start at age 45. We know that modern therapy has improved colorectal cancer survival, and we need to continue to improve. And we also, a lot of our work now is trying to avoid toxicity and giving treatment excessively. And we think that doing ctDNA holds great promise in order to help us figure out how to treat people with colorectal cancer after surgery. So that's the end of my talk. I'd be happy to take any questions.